What's your outlook for EMSA? I mean, do you have any growth strategies?
Well, I think we're going to be more, and I get excited about it. We are in a very good position to help in community medicine since we're mobile. And there are things out there, tools that we can use mobilely that we could keep a lot of people out of the emergency room, save downstream costs, save emergency visits. We've got to get some of the other rules and disciplines caught up with that. But we're at an exciting time because everybody realizes, instead of it being the pundits saying that something is not sustainable, it really isn't. I talked to a guy the other day in a donut shop, stopped me and said, it took me 13 hours out of the emergency room to get so-and-so stitched up. Mm-hmm. And, you go in the emergency room anytime, day or night, and you see what people are in there for. It's an access to health care that they can't get otherwise. So I think we're going to be doing well patient checks in the home. We're going to be setting up clinic visits instead of taking them to the emergency rooms. But there's got to be some major changes. 30% of the time when we go to the scene, we don't transport. There's a variety of reasons, but a lot of them is that transport isn't necessary, or a bandage needs to be applied, or we give a pill or maybe some dextrose to a diabetic, and there's no reimbursement for that. But yet, none. We only get paid unless we transport. And think about how much money we cut out of the downstream costs, the emergency room visit, the transport, the doctor's time, all of that, when we were able to give the patient that's insulin dependent and hasn't taken their insulin, or the person that slips on the curb and cracks his head. We got to be smarter in how we're utilizing our resources, and I think that's coming. I think we will very much be a player in the community health picture.
Technology is obviously going to play a major role as well. There's a lot of legal rules that have to be worked out about that. But the cost of keeping up with it also is something that's going to...
It's a challenge. We're working nationally right now to bring Medicare up to date of what some of the things are that are costing us that weren't. In 2007, when they set the rates, didn't even exist. We have a CPAP on the ambulance. You've heard that people talk with sleep apnea, use a CPAP. Well, we give that to people that are having trouble breathing that in the past would have to been intubated, tube put down their throat, and then they have to stay in the hospital a day. Well, now they get that treatment and there's no hospitalization, the tube's not put down. There's all sorts of examples of where we had to do more time-consuming, costly procedures to cheaper ones that are done out in the field. We got American Medical Response, AMR. It's the largest ambulance provider in the nation, private sector. And they've got a whole division that's just looking at things that you astutely brought up, like lab equipment that's now portable. All sorts of different mechanical pieces that they can run tests and send it via the web back to the doctor, pictures back to the doctor, blood pressures, blood sugars. All these things that require you to go somewhere now can be sent via the web and accurately. But people don't realize a cot today, the cot that we pick a patient up with, that's battery powered, is $13,500 a piece, a cot. The defibrillator, the thing you see on TV and they say clear and they shock, they're $38,000 a piece. Portable ventilator that helps you breathe in the back of the ambulance, it's $13,000 to $17,000 depending on how it's equipped. An ambulance strip is last ones were $135,000 a piece. All these costs, while there are great advantages in the field and technologically and clinically, there's a price. And that's why we work to keep our costs down so much so we can afford those things. One of my mantras here has been always to give the paramedic the tools they need to do the job. They are tool dependent. One of the tools is education. That's why we have our own academy here. And then the other thing are the tools in the ambulance to do the job.
Do you see adding more suburbs, more communities?
It would make sense to. There's some political challenges with that. Some areas don't like to be part of a major metropolitan area, but as the governor's task force report said, it makes so much sense. It allows the jurisdictions to use their valuable resources in other areas. We are a major healthcare center here, so the surrounding communities come into Tulsa anyway with the patients. You know, the way we position ambulances time of day and day of week, and we have these suburbs driving into Tulsa anyway, it just makes a lot of sense. Hopefully the consolidation idea will continue.
When's the last time you added it?
Been Oklahoma City.
So you haven't added a city since 1990?
No.
Wow.